Good morning, ladies and gentlemen. Now I would like to welcome you to our symposium. My name is Jan Mehrholz. I'm a German physiotherapist, researcher and professor. And I'm delighted to have very good speakers today. Our speakers today are Pollock from Scotland, and Moseley from Australia, and Rebecca States from the United States of America, and also me. This symposium will focus on three main points. The first point is Cochrane reviews and evidence for stroke rehabilitation. The second point is the quality of systematic reviews of physiotherapy interventions. And the third point is evidence-based clinical implications from key Cochrane reviews related to physiotherapy for patients with stroke. Our learning objectives of this symposium are therefore, first, to recognize the relevance of Cochrane systematic reviews to clinical physiotherapy practice and to know where there currently is evidence relating to physiotherapy after stroke. Second, to understand the methodologic advantage of Cochrane systematic reviews and the importance of high-quality reviews of evidence relating to physiotherapy. The third objective is to have a detailed understanding of the clinical implications of three key Cochrane systematic reviews to stroke physiotherapy practice. It's now my very great pleasure to introduce our first speaker, Pollock. Dr. Pollock is from the Scottish Government's Nursing, Midwifing and Allied Health Professions Research Unit and is a Cochrane author and editor on the Cochrane Stroke Group. Dr. Pollock will give us an introduction to the Cochrane Collaboration and stroke physiotherapy.
Thank you very much, Jan. What I'm going to be doing this morning is to start by confirming what we mean by evidence-based practice, and then I'm going to introduce the Cochrane Collaboration, Cochrane Systematic Reviews, and then finally I'm going to very briefly give you an overview of the sort of Cochrane reviews that are relevant to physiotherapists working in stroke care. So evidence-based practice. Now I think and hope that as a profession we all do now have a good understanding of what evidence-based practice means, and we understand that it means using evidence to help us make the best possible treatment decisions for individual patients. But 30 years or so ago this wasn't the case, and evidence-based practice wasn't recognised even as a term, let alone as a concept. And this man, Archie Cochrane, was quite a pioneer in his time in terms of championing evidence-based practice. And what Archie Cochrane stressed was that evidence-based practice was about choosing the right treatment and delivering it in the right way at the right time to the right patient. And when Archie Cochrane was talking about evidence, he was talking about research that came from reliable, relevant, valid research evidence. Now, if we're talking about the effect of a treatment, then a randomised controlled trial is an appropriate research methodology. And that's because a randomised controlled trial takes a group of patients, randomly divides them into two groups, and then does everything the same for the two groups, apart from the fact that one will get one treatment and the other group will get another treatment or control treatment or no treatment at all. So if a randomised controlled trial is carried out well, then it can give us the valid, reliable, relevant research evidence that Archie Cochrane was talking about. Now, randomised controlled trials and systematic reviews that pull together a whole lot of randomised controlled trials are now recognised as being the best form of evidence if we want to make a decision about the effectiveness of a treatment. There are now many hundreds of thousands of randomised controlled trials, which is fantastic news in terms of evidence-based practice. The numbers will vary slightly depending where you look, but there are also many thousands relevant to stroke care and several thousand relating to physiotherapy and stroke. These numbers are possibly a bit conservative, if anything. But if we were all to read one randomised controlled trial 6 days a week for the rest of our lives, we might just about keep up with the research evidence that's coming out. Of course, this is completely unrealistic, completely unachievable. There's no way that a health professional can keep up to date with this sort of evidence base. And it was with this recognition that the Cochrane Collaboration was established. So the aim of the Cochrane Collaboration was to help health practitioners carry out evidence-based practice. And the way that they do that is to carry out systematic reviews of randomised controlled trials. The Cochrane Collaboration was set up around a number of core principles. They build on the enthusiasm of individuals. So enthusiastic practitioners anywhere in the world who are interested in addressing a particular research question will work together in equal partnership wherever they are in the world. And another fundamental principle is the fact that it's all about helping people being able to do evidence-based practice. And if you're going to do that, then you have to have evidence which is of very high quality. And you have to have evidence that's accessible and evidence that is up to date. So the Cochrane Collaboration now has over 28,000 of these enthusiastic individuals working on Cochrane reviews, and they come from over 100 different countries. And just this year, the Cochrane Collaboration was officially recognised by the World Health Organization. So it is truly an international organisation and an internationally recognised organisation. True to its principle of not having any geographical boundaries, the Cochrane Collaboration hasn't got any geographical centre. It has got a number of coordinating centres which have geographical bases in different parts of the world. So there's a UK Cochrane Centre, an Australasian Cochrane Centre, a Chinese Cochrane Centre, and these centres do coordinate the work in different parts of the world. But many of the different groups and networks work together in a more virtual way. However, it's the collaborative review groups that are responsible for actually carrying out the systematic reviews. And these review groups are structured around clinical specialities. So there is a Cochrane Stroke Group. Now, it's the role of the Cochrane Stroke Group to ensure that it supports authors in carrying out systematic reviews, that the quality of the systematic reviews are maintained, that the systematic reviews are up to date. The Cochrane Stroke Group also has the role of trying to maintain a register of stroke trials. And they aim, with a full-time research coordinator, to try and identify every single randomised controlled trial relating to stroke in the world. And they have a database of those. The main output from the Cochrane Collaboration is, of course, the Cochrane Library. And this is an electronic library which houses the Cochrane reviews. At the moment, there are over 4,600 Cochrane reviews available on the Cochrane Library. The Cochrane Library also has a database of other systematic reviews that they've identified through systematic searching. So these are other systematic reviews not done within the Cochrane Collaboration, and there's references to over 14,000 of those. And it also has an enormous database of randomised controlled trials. So this will contain all the randomised controlled trials that the Cochrane Stroke Group has identified through their searching. So far I've talked about evidence-based practice and I've talked about the Cochrane Collaboration, and I've mentioned systematic reviews quite a lot, but I haven't said what they are. Now, really the best way to show you what a Cochrane systematic review is to give you a real example of it, and that's exactly what Becky and Anne are going to be doing later on. So it's really my role to give you a bit more of an overview of what a Cochrane systematic review is, and possibly to point out some of the things that make a Cochrane review different from other systematic reviews. Now, Anne's also going to pick up on some of the methodological differences between Cochrane reviews and other systematic reviews later on. So Cochrane systematic review starts with a question. So somebody, an enthusiastic individual anywhere in the world, will submit that question to the Cochrane Stroke Group and say, I think there should be a review around this question. The Cochrane Stroke Group will check that that's a clinically relevant question. They'll check it doesn't duplicate any existing evidence or any ongoing reviews. They'll check that it's an appropriately formed and focused question. And there might be a bit of dialogue between the Cochrane Stroke Group and these enthusiastic individuals to actually form an appropriate question. Once that question is accepted and registered with the Cochrane Stroke Group, then the authors carry on and write a protocol. A protocol is basically a detailed description, written description, of all the methods that will be used during the process of the review. And the idea is to write down what you will do in any given eventuality. So you actually state, if I find these sort of randomised controlled trials, I'll do this, but if I find this sort, I'll do this. The reason for writing all this down in advance is that it's a great way to avoid the introduction of any bias, because of course you can't be swayed by knowledge of the evidence that there is out there if you don't know what it is. Once the authors have written the protocol, they submit that to the Cochrane Stroke Group. The Cochrane Stroke Group then put it through a process of peer review. So it's looked at by methodological experts, statistical experts, content experts. Those people read it and then submit comments back. And it will go back to the authors then to do any necessary amendments, clarifications to the protocol. And that can actually continue several times until you end up with a protocol which is as robust as possible. At that point, the protocol is accepted and it's published in the Cochrane Library. The authors then set out to do what they said they would do. This very simply involves searching for any randomised controlled trials relevant to their question. And the basic rule is that you're trying to find absolutely anything, whether it's published or unpublished, and regardless of what language it's written in. Once they've done the searching, then they apply the inclusion criteria that they had written in their protocol in order to identify the trials that do meet the question. At this point, it's normal to have two reviewers working independently doing this, as this is another very good way to avoid the introduction of bias. You can't be swayed, the review can't be altered by the mistakes of one person or the personal opinions of one person. Once the trials to be included in the review are identified, then the methodological quality of those is assessed, again by two independent reviewers. And then if the included trials have got relevant outcomes, the authors extract data from them. And that extracted data is then synthesised in a systematic way. It might be appropriate to carry out a statistical analysis of the data, which is called a meta-analysis, which involves pooling the data from different trials together, really to come up with a sort of average result. Again, we're going to have some really nice examples of meta-analysis later on, so I'm not going to say any more about that just now. Once the data is synthesised, then the authors write discussions, conclusions, recommendations. Now, another really good advantage of Cochrane systematic reviews is that they're all written in a very systematic and structured way. So once you've read one, it makes accessing further Cochrane reviews much easier as you're familiar with the layout. When the authors have finished writing this, they submit it to the Cochrane Stroke Group, and as for the protocol, it undergoes a process of peer review, so looked at by methodological, statistical and content experts. And again, it's very likely to go back to the authors requiring clarification, amendments, and that process continues several times until the review is as good as it possibly can be. And at that point, it is accepted and published on the Cochrane Library. Now, what I've not got on here is the fact that then the authors should continue to update that review on a sort of every 2 or 3 years so that they include any new randomised controlled trials into the review. So the reviews on the Cochrane Library should be up to date. So what is there that is relevant to stroke physiotherapists? Well, the Cochrane Stroke Group has completed 135 systematic reviews relevant to patients with stroke, and they've got 35 ongoing reviews. I would say that 42 of these are clearly relevant to physiotherapists working in stroke rehabilitation. And about half of those are specifically looking at physiotherapy interventions. So this is fantastic. We have a great evidence base in the form of Cochrane reviews for physiotherapists working in stroke care. So I want to very briefly finish just by giving you a very quick overview of some of these stroke rehabilitation reviews. I haven't really got time even to give you the full titles, so it is going to be a whistle-stop tour. So there's a whole lot of Cochrane systematic reviews looking at the effect of specific interventions to improve movement and function following stroke. These are some of the interventions covered. The last couple there are ongoing reviews, so they're protocols. There's a whole lot looking at specific interventions to improve gait, and we're going to hear about a couple of these ones later on. And there are a whole lot to do with specific interventions to improve arm function. Everything on the bottom row there are protocols. So this is very exciting. It's an expanding evidence base. We're getting new reviews happening all the time. There are a couple to do with shoulder pain and subluxation. Now, the reviews that I've mentioned so far have mainly been concentrating on the effect of one specific intervention. However, there's also a whole series of Cochrane reviews that look at the impact of any intervention on a more clearly defined clinical problem following stroke. And these are some of the problems that are covered. Again, everything in the bottom row there is ongoing rather than completed, but exciting in terms of us having this expanding evidence base. And then finally, there's a series of reviews looking at service provision, which again are relevant to physiotherapists working in stroke care. So in conclusion, I hope that very brief introduction has inspired you to go out and to read some of these systematic reviews and to use them to inform your clinical decisions that you're making with your patients. And I hope that perhaps some of you will have the enthusiasm to step forward and to help us identify the gaps that we've still got in this evidence base and to do some new systematic reviews to address those gaps. Thank you.
Thank you very much, Alex, for this very excellent presentation. I would like to remind you that we will have enough time to discuss some points with the speakers after all presentations have finished. And it's my great pleasure to introduce now our next speaker, Dr. Anne Moseley. Dr. Anne Moseley is from the George Institute for Global Health. She has authored 4 Cochrane reviews and 1 in stroke. Anne will talk now about methodological issues associated with Cochrane reviews. Thank you.
Thank you very much. So the intention of this section of the symposium is to discuss the quality of systematic reviews in physiotherapy, and more specifically to compare the quality of Cochrane reviews compared to reviews conducted outside the Cochrane Collaboration, and they're the other reviews which Alex referred to. The methods used in Cochrane reviews have been developed over 20 years. The Cochrane Collaboration provides extensive training in conducting systematic reviews about the effects of interventions. This includes both internet-based and face-to-face workshops and this very comprehensive detailed Cochrane Handbook of Systematic Reviews of Interventions. Cochrane reviews are conducted using explicit and detailed procedures. Before the protocols and reviews are published on the Cochrane Library, they also undergo a rigorous peer review process by the relevant Cochrane group. And it's this combination of the procedures used and the review process that distinguishes Cochrane reviews from non-Cochrane reviews. I've been asked to present this component of the symposium because of some work I lead looking at this issue about the quality of Cochrane versus non-Cochrane reviews. And the first part of the data I'll be presenting will be based on a paper that was published in the Journal of Clinical Epidemiology in 2009. My presentation will also be based on a survey that we're currently conducting, and I'll be presenting you some preliminary data from. Both surveys used the same sort of methodology. So the first survey involved us surveying 200 systematic reviews, which had been randomly selected from reports of reviews indexed on the Physiotherapy Evidence Database. This sample included 63 Cochrane reviews and 127 non-Cochrane reviews. And the methods we used were, we looked at the methods and described what they did for search strategies and extracting data and all the steps involved in a review. We also assessed the overall quality of the review, and both these processes were done by 2 independent raters with arbitration by a third rater. Now, the thing that distinguishes the second survey that I'll be presenting results from was that we actually paired the reviews. We matched the reviews for the patients, the patient group, the interventions, and also the year of publication. So we're comparing apples with apples in the second survey, but in the other survey we're looking at a bowl of fruit and seeing what happens with Cochrane versus non-Cochrane reviews. And as indicated in this slide, what I'll do to distinguish the 2 survey results is the results from the first 200 randomly selected reviews will be presented in white, whereas the paired 31 pairs of reviews will be presented in orange. Cochrane reviews had higher quality than non-Cochrane reviews, and I'm presenting means and standard deviations here. The average quality, as measured with the Overview Quality Assessment Questionnaire, was 5.2 out of 7 for Cochrane reviews and 2.7 out of 7 for non-Cochrane reviews. And so that's a mean difference of 2.5 points, quite a large difference. The results from the 31 paired reviews were consistent with the original data, but we used a different scale which had come out in the literature since the first review was accepted for publication, and it's an 11-item scale called the AMSTAR. And I'll just present this slide, which is each of the 11 items on the AMSTAR scale for the 31 paired reviews. I've indicated for both the Cochrane and non-Cochrane the percentage of each category that fulfil the criteria for the item. The only item which was similar for both Cochrane and non-Cochrane reviews was evaluating publication bias, and you can see by the percentages that both Cochrane and non-Cochrane reviews actually didn't investigate publication bias very frequently. For all other items on the AMSTAR, Cochrane reviews fulfilled the criteria significantly and usually at least twice as more frequently as non-Cochrane reviews. So just briefly, about twice as many Cochrane reviews established their design before the review was conducted. And as Alex just described, this process of establishing a protocol really reduces the bias in Cochrane reviews because you have a set of rules to follow and report and to analyse the results. Cochrane reviews were also 3 times more likely to have used 2 independent reviewers to select trials and extract data, and that reduces the error involved in the review. So you can be much more confident that the review hasn't mis-extracted data, or extracted wrong data, or also missed any trials. Cochrane reviews also implemented a more comprehensive strategy to search bibliographic databases and grey literature. And conducting a comprehensive literature search means that you identify all the trials done in a particular area, not just the ones that are easily accessible, so that have been published in English language journals, for example. Cochrane reviews were more likely to report the list of included studies and excluded studies and actually describe what happened in the included studies. Cochrane reviews were also more likely to have assessed the quality of studies and to use this information about the quality in interpreting and formulating their conclusions. And lastly, Cochrane reviews use more appropriate methods to combine studies than non-Cochrane reviews. So I'll just quickly go through some of the components of the methods. All Cochrane reviews systematically named the databases used in their search strategy compared to 96% of non-Cochrane reviews. And there was a tendency for Cochrane reviews to search more databases. So they searched a median of 5 databases in Cochrane reviews compared to 4 databases in non-Cochrane reviews. And this data is consistent for the original survey and for the survey of the 31 paired reviews. And just out of interest, this is the 8 most commonly searched databases in the systematic reviews that we looked at. While 95% of Cochrane reviews included supplementary search strategies for grey literature, so this is literature that's not indexed on mainstream databases, might not have been published, only presented at conferences, maybe written in languages other than English, only 85% of non-Cochrane reviews did so. And again, there was a tendency for Cochrane reviews to use more strategies than non-Cochrane reviews, so a median of 2.5 compared to 2 strategies. And the results from the 31 paired reviews were absolutely consistent. And the 2 most common strategies used for finding grey literature were citation tracking, so looking at reference lists for published papers that are included in the review, and contacting experts to see if they are aware of any other trials that have been done in the area. Cochrane reviews were more likely to have assessed quality of included studies, and 100% of Cochrane reviews did this, while only 64% of non-Cochrane reviews. And similar results again for the survey of 31 pairs of reviews that we've done. The scale most commonly used to assess quality was the Haddad scale, but for Cochrane reviews, the risk of bias system and also the allocation concealment system was more used in those reviews, and that's part of the software used to structure the review. How the reviews reported the actual data of trials was very different, and this is quite interesting because Cochrane reviews were more likely to report the outcomes of dichotomous data. And just to diverge a little, dichotomous data or dichotomous outcomes are those that can be divided into 2 categories. So for an example of a dichotomous outcome that Jan will be presenting later is, can somebody walk independently or not? A yes-no question. Whereas continuous outcomes are outcomes measured on a scale that's continuously variable, like walking speed. So Cochrane reviews were twice as likely to actually report data from individual trials that was dichotomous, and also they reported slightly more continuous outcomes. The results from the 31 paired reviews was a little bit different. So in this case, Cochrane reviews were much more likely to present both dichotomous and continuous outcomes. And this means probably in a number of non-Cochrane reviews, they actually don't report the data of the individual trials to give you an idea of the size of effects of treatments. In terms of analysing the results, Cochrane reviews were more likely to pool data using meta-analysis, where non-Cochrane reviews were more likely to use vote counting or levels of evidence approach. And as Alex pointed out, meta-analysis is the statistical process of combining trials in order to produce an overall estimate of the average intervention effect size based on the available trials. Vote counting involves deciding whether the treatment was statistically significant or not, and counting a yes vote for ones that were statistically significant and a no vote for ones that weren't. So it doesn't give you that rich information about the magnitude or how big an effect is it clinically worthwhile. The results for the 31 paired reviews were consistent with the original survey, and we're just having a look at this data down here, because I think this 48% might not be quite right. There might be more people looking at levels of evidence in that group, so we're just double checking that data. In terms of the conclusions drawn by Cochrane and non-Cochrane reviews, non-Cochrane reviews were more likely to conclude that there was a benefit of therapy, whereas Cochrane reviews were more likely to conclude that there was insufficient evidence, there was not enough evidence to make a call one way or another. And we think this might be partly an artefact of we're looking at a bowl of fruit with this original survey, that some reviews evaluated interventions that were much more complex and difficult to quantify, or that might not be effective, whereas others might have, that we were comparing them to, were looking at interventions that are clearly effective. So with the 31 pairs reviews, we think this is a better indication of the conclusions drawn by, the reviews were paired by the types of patients and the interventions and the year of publication. And in this case, Cochrane and non-Cochrane reviews were similar in concluding that there was insufficient evidence to make a conclusion about the effect of treatment. And they were also similar in describing if there was a beneficial effect of treatment. But Cochrane reviews were much more likely to report that there was no effect of some interventions on some outcomes. So to summarise, reviews conducted under the Cochrane Collaboration editorial system are more likely to establish their methods a priori, search more databases, use more strategies to identify grey literature, use a more rigorous system to select studies and extract data, assess, report and use quality of trials, and to pool data using meta-analysis. So this means Cochrane reviews were of higher quality than non-Cochrane reviews, and they can be used to guide clinical practice. Thank you.
Thank you very much, Anne. It's my great pleasure now to introduce myself for the next talk. My task is to give you examples of evidence from 2 Cochrane reviews. This is my name. I work here in a clinic, Clinic Bavaria in Kreischer. It's a clinic in Germany. And I work here also, and work here in 2 universities. And our next slide that I'd like to present you should remind us that my talk about electromechanical devices and evidence of these devices is all but not new. Here we can see a very good example, an old example from 100 years ago from northern Germany, from Hamburg. This is one of the first mechanical gym hall. And it's all but not new electromechanical devices. However, in the latest years, in the recent years, there were very good examples of electromechanical and even robotic devices developed. You can see some nice examples here for the lower limb, 4 examples. And here we can see 3 devices for the upper limb. And all these devices have a couple of advantages to improve the repetitions in training after stroke, for example. However, they have also some disadvantages, unfortunately. First of all, they be a high cost. They are very costly. And the second disadvantage might be that the scientific evidence is lacking for such electromechanical devices. Therefore, the aims of 2 Cochrane reviews of our group was to review the available literature systematically and to assess the effects and the acceptability of patients of upper and lower limb technologies of these devices. And if you don't mind, I would like to skip the methods a little bit. We did 2 protocols for this Cochrane reviews, one for the lower limb, for walking training after stroke, and we did another protocol for electromechanical assisted training for arm movements after stroke. And all our methods are described and published in these both protocols. And if you like, you can read them in the published version. Let's come to our first example of electromechanical assisted therapy. The first example is about to improve gait function after stroke. And what we did was, as Anne pointed out, a systematic search. We searched in Cochrane Stroke Group, Trials Register, and also in a couple of other databases, in Central, Medline, Embase, CNAL, AMIT, SpotDiscuss, Pedro, Compendex, and InSpec. And our aim was to find all randomized controlled trials who have investigated electromechanical assisted gait training after stroke. Let's come to results. We defined our primary outcome parameter as the recovery of independent walking after stroke. And we defined independence in walking after stroke if patients could walk 15 meters without any assistance of any persons. So we said this person is walking independently, and that was our definition of walking independently. Here come our results for our primary outcome. It's a dichotomous outcome, whether people could walk these 15 meters or not. And what we see here, it's a pooled analysis. We included 70 studies. That's not bad. 70 studies. It's good evidence for training. And what we see here is the main effect, the pooled effect. Have a look on this black diamond. And what we see here, the main effect, if we pool all 17 trials, is that we have a significant improvement if electromechanical gait training is used after stroke. Let me say in other words, we included more than 800 people after stroke, and the number needed to treat is 6. This is a very large effect. In other words, every 6 gait dependency after stroke is avoidable if electromechanical assisted gait training is used after stroke. It is a large effect, in our opinion, and statistical significance, as we can see here in this slide. Okay, our primary outcome was clinically effective and significant too. What about our secondary outcome? Our secondary outcome was walking speed. Do people benefit in walking speed when they use electromechanical assisted gait training? And the answer is no, unfortunately. A little bit sad about this pooled analysis because we have to explain why people achieve independent walking but not improve their walking speed. So I could say one reason could be there are not enough studies. There are just 50% of all studies who investigated walking speed. Another reason could be, or another explanation for this not significant results could be that devices used, the robots and the machines, have a limit of gait speed when they use. They have a limit of 1.8 or 2.0 kilometers per hour. They are not designed to improve walking speed. That could be a reason that the results here are not significant. Our secondary outcome was walking capacity. How long can people walk after stroke if electromechanical devices are used? And what we see here, unfortunately, again, no significant and no clinical, just 6 meters, no clinical effectiveness when electromechanical assisted gait training is used. What's the reason for this? We actually don't know. We are still sad about this result. But let's come to my reason for walking speed. Maybe there's not enough studies. And another reason is the devices are maybe not developed, not designed to improve walking capacity. That could be one reason for this. We don't know. What about acceptability? How do patients accept these devices? We measured acceptability with the dropout rate during intervention period from patients during the study. And what we see here, we see no significance. That's good in this slide. Acceptability was comparable between these groups, between the groups of electromechanical assisted gait training and of the control group. We could say acceptability isn't different if electromechanical devices are used. These are good news. So let's summarize our first slides. We have to interpret with cautions because there is effects. We showed effects, but there are variations between the trials we found with respect to duration of treatment. Some trials investigated 2 weeks of training, some trials of 9 weeks of training. There are variations in terms of frequency of treatment. Some trials tested or investigated 3 times a week, sometimes 5 times a week. And there were surely differences in ambulatory status of patients. Some people were already ambulatory at study onset. And I will pick up this point later in this talk. The second point is that some trials tested electromechanical devices in a combination with functional electrical stimulation. It's another point, and we have to interpret with caution these results. Maybe there are other questions, post hoc questions, who arise from this first analysis. Maybe the burning question for many therapists is what kind of therapy for which patients? And there's no easy answer, as you know. Maybe we might ask us 3 burning questions. The first question is, when should electromechanical assisted gait training be applied? In the acute, subacute phase after stroke, or rather in the chronic phase after stroke? The second question we might ask could be, does the device matter, the type of device? Maybe the device does matter. And the third question might be, is there a difference between patients who are already ambulatory or patients who are non-ambulatory? And I try to give you just 3 short answers to these 3 short questions. First question was, does it matter in which phase after stroke? And the answer is yes, it does matter. From our data, from this included study, we see the biggest effects we see in the acute, subacute phase, defined as the first 3 months after stroke. We see a very good effectiveness of these devices in improving gait ability, but we don't see effects in the chronic phase more than 3 months after stroke. But beware, here are just 5 studies in the chronic phase and many more studies in the acute phase after stroke. So maybe it makes more sense to train patients in the first 3 months after stroke with these devices. The second question was, does the device matter? And there's no easy answer to this question. And there's no direct comparison between different devices used in neurological rehabilitation. From an engineering point of view, we could make a decision line here between 2 device types or 2 types of devices. The one, it's the classical robotic principle. It's exoskeleton principle. And if you heard about Stanislav Lem, that's the science fiction author who described first robotic principles in science fiction literature. And it's a little bit like the classical robotic principle. Exoskeleton encompasses the leg and moves the leg during the gait cycle. A completely different engineering principle you can see here on the left side. It's so-called from engineer's end effector model. The force development comes from distal, and there are no exoskeleton who encompasses the legs and moves the legs. So we have 2 possible principles of device. And now let's answer the question. If we compare indirectly the end effector device groups and compare with the exoskeleton group, we can see here's a difference. Maybe it in favor for the end effector device group. This is the group with a distal force development. And what we can see here in the exoskeleton group, the effects are quite lower. And the subgroup we compare here are different, statistically different, as we can see here. It's a P 0.03. So maybe the device does matter. We don't know exactly. Our data shows that end effector-based electromechanical assisted gait training is more effective, maybe more effective than the exoskeleton approach so far. So what about ambulatory patients? This is our third question, our third post hoc analysis. And for our German friends, I have left some slides in German here, as you can see here. And does it make sense to treat already ambulatory patients in robotic devices? And the answer is maybe not. If we have a look on patients who are initially not ambulatory, who cannot walk alone, they improve the ambulatory status. However, patients who are already ambulatory, they don't improve the ambulatory walking abilities. So these were 3 short answers to my 3 asked questions. Let's summarize the evidence so far for benefit of electromechanical assisted gait training. Non-ambulatory patients, especially in the acute phase after stroke, who receive electromechanical assisted gait training, maybe especially end effector-based gait training, in combination with physiotherapy, are more likely to achieve independent walking than patients receiving gait training without these devices. This is the message for my first example for the lower limb. You ready for the second example? All right, let's do it here. Example 2 is about electromechanical assisted arm training after stroke. And here you see again the 3 slides, 3 photographies from the first slide. And we did again a systematic search, same methods, but different search. We searched the Cochrane Stroke Group Trials Register. We looked at Medline, Embase, CINAL, AMED, and so on. And I skipped the methods a little bit and come directly to results. What is the evidence so far for electromechanical assisted arm training? In our primary outcome, we defined improvements in activity of daily living. And the research question was, does arm robots or electromechanical assisted arm training does improve activities of daily living after stroke? Here's the pooled analysis. So what you can see so far, there are just 6 studies who investigated electromechanical arm training after stroke in respect to activities of daily living. And what we see here, again, a quite disappointing slide. There are no clinical, no statistical effects. And what we see here is activities of daily living maybe not improving when using robots or electromechanical assistance. Our second research interest was how is the acceptance, again defined as dropouts during intervention period, during training with these robots or devices. What we see here, there is no difference between train with devices or without devices in acceptance in dropout during the intervention period. So, the question is, the robots for the arm doesn't really matter. Is it the case? I think we got 2 secondary outcomes, and maybe arm function might be improved if we use electromechanical or robot-assisted arm training. What we see here, 7 studies investigated arm motor function after stroke, and what we can see, how lucky we are, a significant improvement of arm motor function. That means if you use electromechanical arm training, then arm motor function might be improving after stroke. Another secondary outcome of interest was, does arm strength improve when using such devices? And just 5 studies investigated arm strength, this robot training. What we see here, a very heterogeneous picture, but the main effect is still significant, and what we conclude from this slide is arm strength might improve if you use electromechanical assisted arm training after stroke. So let's summarize our second example of Cochrane evidence. What is the evidence for benefit of arm robots? First, we might argue that arm strength and motor function improves. However, activities of daily living, our primary outcome, don't improve. Why? Perhaps this is because they are just small effects due to electromechanical arm training, or maybe, we don't know exactly, we have just bad assessments to assess activities of daily living. Or maybe it's a mixture of both, we don't know exactly. So, one more slide, and I have to thank you for your attention. I'm really busy today. I'm not used on it. It's my thank you, Jan, for this presentation. It's my great pleasure to introduce our next speaker, Dr. Rebecca States from the United States. She is primarily an educator in physical therapy at Long Island University, Brooklyn campus, and a teaching institution. Dr. States has also co-directed federally funded grants which focus on community-based health education and exercise for diverse older adults. Rebecca will give us a very nice example, another example, of evidence from a recent, very nice Cochrane review. Please, Rebecca.
Good morning, everyone. I'm going to focus on a Cochrane review that I and my colleagues did, which kind of goes the opposite extreme from Dr. Mehrholz's review. So where he looked at high-tech interventions that are fairly costly and require a fair amount of resources, our group looked at Overground Gait training, an intervention which can be done almost anywhere, in almost any setting, and is done very widely all across the world. So I'm going to both summarize our review today and then talk a little about the relationship between our findings and the findings of related Cochrane reviews on mobility deficits for people with stroke. The purpose of our review was to specifically assess whether Overground physical therapy gait training improved walking ability for individuals with mobility deficits subsequent to in the chronic phase of stroke. And we were interested in this in part because it is such a ubiquitous treatment approach. But in part because of that, it becomes a little difficult to define exactly what we mean by Overground gait training. So we focused on gait training in the sense that it requires face-to-face interaction between the patient and the therapist. So we were not thinking so much of home exercise. And it had to be interventions where the main focus was on practicing overground walking. That could include real-time observation of the person's gait, as well as cueing, all kinds of different cueing activities, as well as working on pre-gait activities like weight shifting exercises, step up, step down, various dynamic balance activities, a whole range of more isolated aspects of gait than the entire walking pattern, but nonetheless done within the context of trying to improve mobility. Some of the things that we restricted our definition on was to say we were not going to look at interventions that involved high-tech resources to work on gait. So we were not going to look at body weight supported treadmill training or the kinds of robotic and mechanical devices that you just heard about, nor at functional electrical stimulation. We also excluded exercise programs whose specific purpose was to train some other aspect of capability, like programs for strength training or endurance training, but that were not oriented towards improving gait. We looked at people who were in the chronic phase after stroke, at least 6 months since they had a stroke, and people who presented with mobility deficits. We chose in part to look at people in the chronic phase because we imagined that overground gait training is so prevalent in the acute phase that we would not find any randomized controlled trials where overground gait training was not used in the acute population. So another central issue for us in doing this review was to think about exactly what we wanted to measure in order to assess whether overground gait training was beneficial. And we elected to focus on gait function as defined by a multidimensional ordinal scale that was validated for people with stroke. So some examples of these scales include the Rivermead Mobility Index, the STREAM, the Bartel Index, the Motor Assessment Scale. And the rationale for heading this direction was that we really wanted to get a sense of whether overground gait training was helping people be able to walk effectively in their everyday environments. So we weren't interested in getting a sort of tight clinical measure of gait, but rather in looking at the real world effectiveness. And that's why we use these multidimensional measures. We did also look at some secondary measures that were more focused in nature, like gait speed over a short distance, the timed up and go test, the 6-minute walk for looking at endurance, and we wanted to look at quality of life, adverse events, and so on. As with the other Cochrane reviews, we searched a broad range of databases, including most of the ones that you saw in the previous talk. And in the process of doing that, we came up with over 3,700 citations that might have been relevant to this question. In sorting through those, we ended up reviewing 92 of them, and then discovered that only 9 of the published randomized controlled trials actually met our inclusion and exclusion criteria. The most common reasons that studies did not meet our criteria was that upon close inspection, they were either not a randomized controlled trial, the participants in the study had had their stroke less than 6 months prior to enrolling, or the control condition included overground gait training. And that was a very common issue because many studies are done where overground gait training is part of the control condition rather than tested for its own effectiveness. So we ended up with 9 studies to include in our review. And I have to say right at the beginning, that's not a lot of evidence, just on the face of it in terms of the number of randomized controlled trials that tested this question. Of those 9 studies, 2 were crossover designs, so we focused on the first half of those crossovers. 5 of the studies did do some follow-up, though not on all of the measures that were listed. And some of the studies had additional groups or participants that we did not pay attention to because they were not relevant for our question. In these studies, we required that all of the studies have an experimental group using overground gait training and a control condition which either consisted of no treatment whatsoever or some alternate form of exercise which might be considered a placebo. Most of the studies had no treatment. 3 of them had an alternate form of exercise. And they've ranged in size from anywhere from 10 participants up to 170, for a total of almost 500 subjects in this sample. The quality of these studies was moderate and somewhat variable across them. In general, they used random sequence generation and random allocation, though sometimes that was not well described, and so it was hard to tell what happened there. In general, the participants were not blind to which arm of the trial they were in, and unfortunately that's a problem that we deal with all the time in physical therapy. It's very difficult to keep a patient from knowing whether you're doing exercise with them. So, there were no issues with incomplete reporting of data or other types of bias. It's hard to judge whether there was selective reporting of outcomes because none of these studies had published protocols. So, from a methodological point of view, one of the interesting questions here is whether the interventions that were addressed in these 9 included studies were all similar, and did they all really test overground gait training? Well, the interventions were somewhat different from one study to the next. 3 of them looked at individualized physical therapy treatment that was focused on improving gait or mobility. The other 6 studies tested some kind of standardized set of exercises which was aimed at improving gait. One of those studies looked at dual task exercises. Another looked at weight shifting approaches. A third looked at endurance, was doing interventions to promote endurance, and some others did a combination of exercises. But they were a specific set of exercises defined by the authors and tested for their effectiveness. The range of interventions, the range of duration and frequency of intervention was highly variable across these 9 studies, going anywhere from 2.5 hours to 57 hours of treatment, and across anywhere from 1 week to 19 weeks. So it is a highly variable set of interventions that we were looking at. Some of them were administered face-to-face, one-on-one. Others were done in groups. Others, it's unclear from the reported studies. So, having gone through all of that methodology, what do we end up with in the results? And keep in mind that we were really interested in looking at overall gait function, at this broad measure of whether people had improved in the numerous different abilities that go into doing gait in a real-world setting. So it turns out that only 3 of these 9 studies actually measured gait function in that way. And of those 3, and within those 3 studies, each of them measured gait function 2 different ways. Each of them used either the river mead or the stream, and they all also used the Bartell. So we looked at the results for both of those and came out with the same result in both of those, that there was no significant difference between overground gait training and the control condition on this measure of gait function, measured right after the intervention. Looking at the secondary outcomes, the unidimensional measures of gait speed, timed up and go, 6-minute walk, there were some significant findings there. And more of the studies looked at those secondary measures, especially gait speed. However, the size of those effects are relatively small. So if you compare the size of those effects to minimum clinically important difference, for none of these variables did this overall effect reach that minimum clinically important difference. So these were fairly small. None of the studies that we looked at reported quality of life, and there were no differences in adverse events between the control and experimental conditions. At follow-up, the picture changed a little bit. So 3 to 6 months after the interventions had finished, there was a small change in gait function that was evident, but that was based on only one study. So from the point of view of a systematic review, it's hard to know what to do with that. For the secondary variables, the unidimensional ones, there were no differences when measured at the follow-up period. But again, that was only based on up to 3 studies for any one of those measures. So to kind of summarize those findings, there was limited available evidence on this question. And from that limited evidence, the results were mixed. There was no significant effect on the primary variable immediately following the intervention, but there were small effects for the unidimensional variables. At follow-up, things changed, so now the primary variable showed a small effect, but there were no significant effects for the secondary variables. We have to keep in mind when understanding this evidence what some of the limitations are. And of course, the primary limitation here is that there is very limited actual research evidence on whether overground physical therapy gait training has an impact on this broad measure of gait function. In addition, as you could see, the interventions that we looked at as overground gait training were highly variable, and it's difficult to characterize exactly what we all do when we do overground gait training. The outcome measure we chose to look at, well, while it has good external validity, it may not be especially sensitive to small changes. And the follow-up in these studies was limited. So, what do we do with all this? Okay, should we continue to do overground gait training even though this evidence is limited? Why is it that so many of us do overground gait training so frequently, given that there's not a whole lot of evidence out there? And can we cull something from this data to make to make a better way to improve gait function? One possibility, one speculation, and this is merely that, it is merely speculation, is that perhaps part of the reason we all find overground gait training so important is that it also plays a role in educating our clients about how to be safe and how to begin training their own mobility. Even if they don't make great progress in overall gait function, at least perhaps by doing gait training with them, we help them become safe. And perhaps we also provide them the means to then go on to work on additional kinds of therapy that requires more repetitions, that focuses more precisely on a single skill at a time, and so on. Now I'd like to kind of turn from our systematic review to look at how it relates to other evidence from reviews about mobility training for people after stroke. And as noted, there have been a fair number of reviews out there that have addressed the issue of mobility after stroke. There have been Cochrane reviews on circuit class training, on repetitive task training. We just heard about the one on electromechanical gait training. Dr. Pollock has done a review on different approaches, different kind of theoretical approaches to physical therapy. There have been reviews on cardiorespiratory training, and of course Dr. Moseley's review on treadmill training. So there are quite a few systematic reviews out there, even Cochrane reviews, about physical therapy interventions for gait. And what can we take from that whole set of reviews? Well, one thing that our group kind of came to in looking at those set of reviews and considering our own results is that the evidence is somewhat inconsistent. So whereas interventions that focus on a particular task or exercise and do a great deal of repetitive training tend to show results on outcome measures that are strongly related to that task or that type of training. So when you do treadmill training and work on the speed of treadmill walking, gait speed improves. However, as we saw in the previous review, it's very common also in these systematic reviews to see mixed results, that where you may find significant effects on one or two outcome measures, you usually do not see strong effects across the board on the entire range of measures that's relevant to gait function. So perhaps what's going on here is that different types of training address different small aspects of the overall picture of mobility function. And perhaps gait function is even more multidimensional than we have typically talked about it. I mean, gait speed is a great, simple, easy measure to get a sense of people's function, but it doesn't tell you a lot about whether they can walk on uneven roads and get up the steps to their front door and carry a grocery bag while they're walking and that kind of thing. So maybe that multidimensionality of what we do when we walk in the real world is part of why we don't see such consistent findings and such a convincing level of effect from these reviews. And then I want to just take one more moment and put all of this talk about the research evidence back into the framework of evidence-based practice. So we all talk about wanting to use an evidence-based practice framework, and to do that, we need to keep in mind that the research evidence is one part of that picture, and along with that, we need to consider the individual clinicians, resources, and the healthcare environment that person works in, their training and expertise, their knowledge base. And of course, we need to think about what the patient brings to the situation, what their values and expectations of the process are going to be, what they are able to bring to the process. And all of that needs to come together in how we treat the individual in front of us, in addition to these research findings. So to kind of conclude this, we certainly acknowledge that overground gait training is a mainstay of physical therapy rehab in many, many different environments, and it is certainly a critical part of what we do with patients with mobility deficits. Our systematic review on the effects of overground gait training on this multidimensional measure ended up with mixed results. There were no clear benefits for the primary variable. There were small benefits for the unidimensional variables. So I would kind of end up at the position that we need some additional research to figure out interventions that can consistently improve this overall picture of gait function, rather than only being able to improve particular aspects of it. And when we get to the point that we can consistently say that this form of intervention works with a broad range of clients and for a broad range of capabilities with Gait, then I think we will be in really good shape. And I would just like to thank my collaborators, Evangelos Pappas and Yasser Salem, who are both here, as well as graduate students from Long Island University. And also, I would like to thank our many, many clients who inspire us with their perseverance and their optimism at overcoming their major mobility limitations. Thank you very much.
Thank you very much, Becky, for this very nice presentation. And we got 10 or 15 minutes. And I would like to invite you to raise questions by approaching one of the designed microphones here. And please state your name and country before you're posing your question.
Hi, I'm Mike Ellis. I'm a clinical researcher from Chicago. First, I want to say thanks for the great presentation. I'm a big fan of the rigor of the Cochrane process. I really like it. However, it's very painful for me to see 82 of 92 selected RCTs removed from the analysis. Is there any way to... I'm fearful that maybe the inclusion criteria could be too conservative or too rigorous. And what's the effect of loosening it a little bit? Can we capture some of that useful information from maybe the lesser quality RCTs that I think are still possibly important?
Yeah, that's a very good point to raise. However, of those 92 citations that I referred to, many of them ended up not being randomized controlled trials. It was somewhat difficult from the titles and abstracts to determine whether the randomization was part of that process. And another very big reason for eliminating trials was that the control condition included overground gait training. And given my question, I really couldn't use studies that allowed overground gait training in the control condition. That's a very common thing among PT studies. So I would say of those 92 studies, there were really very few that we eliminated because of quality issues, and more it was because they did not fit the question.
Great, thank you.
Can I just add to that, Cochrane reviews, the methodology that we use for rehabilitation reviews, it is not general practice at all to exclude on the basis of quality. So we tend to say we'll include all randomized controlled trials, regardless of the quality, that meet the question, but then we pre-plan to look at the quality and do subgroup analysis according to the quality.
I'm Pam Duncan from the United States, and I just want to applaud all of you for this wonderful presentation. And I want to thank you from the bottom of my heart for always doing the Cochrane reviews, because they are an incredible source of background information for us. However, I do want to bring forth not a criticism of the Cochrane reviews, but as a criticism of our research. So maybe the take-home message that we should take out of this wonderful work that is being done from the Cochrane Collaborative is initiative about how do we address our research questions more methodically. Because if you look at the review in the electromechanical stepper, and a couple of you referred to this, the real challenge in that is that you've got very different control groups. And if you look at the Hornby or the Heidler research questions, they have an active control group of equal dosing, and they didn't find an effect, where some of the other interventions or controls are usual care. And if you really synthesize a lot of the evidence that we see in all of these trials, everything beats usual care. So that what we have to think about in this world, as we are being challenged repeatedly, is how do we design these studies better in a more rapid, accelerated way so that we don't have such heterogeneity in the control intervention, in the timing of the studies, as well as Rebecca stated elegantly, the huge heterogeneity in the exposure to the intervention. So I guess in this, the Cochrane methods are the best in the world, but they really are informing us about how we should do it better, really than always providing us with the best evidence to guide practice. And it's not a limitation of Cochrane, but of the evidence that's there. So I'd just like your responses to that.
Should I? Well, thank you very much. You're totally right with your comments. However, in the electromechanical review especially, the critic on the control group doesn't fit very good because all the control groups matched the therapy time to the experimental group. Almost all 18 studies did it. There were no very differences between control intensity and experimental intensity. But you are right if you say we should use Cochrane reviews to plan new studies or new trials. However, we got a little statistical problem too. It's the question of contrast. If we would like to have a good contrast, to have large effects, we have to use a control group who is less effective a priori. So it's a little bit a statistical problem too we've got if you design a trial. If you use a control group who are very repetitive, very competitive, so we will have very small contrast to experimental groups. So it's not so easy to plan a good trial for the future. It's a question of the contrast too between the groups.
Good morning. My name is Gerard Fluette. I'm from the United States. I was curious if the panel feels that there's a quality to a body of evidence that lends itself to a Cochrane review, that the conclusions of the review are really significantly more valuable than the reading the individual studies themselves. That, you know, if
I think what you're saying is, are the reviews that have successfully pulled randomized controlled trials and demonstrated a large effect? Is that your question?
It's not that as much as you know, to look at, like, there's some of the reviews that you see, they're summarizing 3 or 4 or 5 studies that aren't particularly homogeneous, and or they have limitations in terms of the outcome measures that are focused on. Would you advise us if if those are areas that we should really be considering each study individually on their benefits versus the final conclusions of the review?
Yeah, I do think. Okay, I do think that's a very good question to ask. And I would say that when the evidence is very limited and very heterogeneous, that you do need to go back and look at the individual studies, especially when 1 or 2 of those individual studies are even more on point to the question that you began with. So very often the question that an individual is asking is not going to be precisely what was asked in the systematic review. And certainly if there are studies within that review that get you even closer, by all means, go look at them and understand them in detail. I would just say that one of the functions, I think, of the Cochrane reviews is to point out where the evidence really is available and to help people find that evidence and see the relationships across it.
Thank you.
Microphone 1, please.
Good morning. My name is Louise Roots-Lepitz from Switzerland, and I would like to come back to what Dr. Duncan said and just discuss the randomized controlled trials that we've been seeing. And the thing that really concerns me, and also with the Gait robotic things, is that often the controls are what's called conventional therapy or whatever, and not defined at all. The time is maybe the same, but what they're doing is not declared at all. And one principal investigator, I asked what the conventional group was doing, and they were saying trunk activities and sitting, and the parameter was Gait. And I mean, that just can't fit. And this really concerns me. And most of the controls are not defined, although the experimental group are very well defined, but not the control group, what exactly they're doing. So I just think that's a real problem for me reading these things, and I might like to try the conventional therapy, but I don't know what it is. Okay, thank you.
I don't think this is a problem unique to gait training in stroke, that the intervention is a complex intervention and is difficult to describe in a journal article, and I think that's part of the difficulty we have with informing practice using evidence is being able to understand what the experimental and the control interventions are. And hopefully we're going to be able to work around that a little bit more with advances in reporting of trials and reviews where it's now common practice to have protocols that you can describe interventions more and have supplementary data. But I think you need extra information apart from the trials themselves to actually change practice and translate it into practice.
Tamar Jacob from Israel. I think many of us are aware of the strengths of observational or good observational studies. And my question is to the Cochrane Collaboration. Isn't it about time to add observational studies to the reviews?
The question was whether it would be appropriate to add observational studies into Cochrane reviews. I mean, there are lots of systematic reviews of observational studies, and there's the Campbell Collaboration, which does that, and the Joanna Briggs Institute do systematic reviews of observational studies. And I absolutely agree with you that there is a place for these. And I think the bottom line is that randomised controlled trials and systematic reviews of randomised controlled trials potentially can give us the best evidence. But in the situation where we are just now, where we haven't got very many randomised controlled trials for some of our questions, and the methods of those are sometimes dubious, then I agree with you that we have to turn to observational studies to help us make clinical decisions now, at this point.
Thank you for your presentation this morning. I just wanted to ask, my name is Isaac Sorinola from the United Kingdom. I just wanted to ask about the meta-analysis process during Cochrane reviews. Does it factor into the meta-analysis equation the quality of each individual studies, and if it does, how does it use that in calculating the effect size, the overall effect size in the long run, to determine whether an intervention is going to have a favorable effect or not?
Incorporating quality into systematic reviews is quite a complex issue, and there's no definitive answer. And so the approach taken in Cochrane with doing that is to perform what is called a series of sensitivity analyses. So looking at the overall result, including all trials, and then seeing what happens to your results if you only include trials that really have stringent quality criteria, and to look at that effect. And we haven't been able to establish it in physiotherapy, but in other areas of medicine, the higher quality trials tend to have a smaller effect size in trials. Other ways of incorporating it, which isn't done in Cochrane, is to weight trials based on their quality in the meta-analysis process, but that's not done. Yeah.
My second question is centered around the multidimensionality of some of the things that we measure. Is it probably because some of the interventions we choose or we use have not really been looked at the very basic level to look at their impact on the physiology, on the brain, on things like that, so that we can be able to target interventions at the sort of like at their causal relationship with some of the functions that we're interested in.
Yes, the multidimensionality is a big issue, and I think in addition to trying to understand the physiological basis for many of our interventions, which is certainly lacking, but even before we get there, I think coming back to the issue raised by Pam Duncan, it's often even difficult just to understand exactly what was done for a particular intervention or a particular control condition. So there's a lot of different parts of that probably need to be addressed, including getting better methods for describing exactly what it is that we're doing during interventions and control conditions, and indeed just explaining what's going on in clinical practice outside of studies. But then also connecting each of the many different aspects of the interventions to their physiological rationales. And, I think individual researchers focus on small bits of that, and we can only build it up over time to try and get to that big picture.
Thank you. I can't see any more questions, and it's 10 o'clock too. So I would like now to thank all speakers for their very valuable contributions. And I would...
Thank you, Tia.
I would like to thank you all for attending this symposium and will draw your attention to the next programming points. I hereby declare the symposium is closed.